Yeah. Thank
Wonderful.
you so much. This was really wonderful. Yeah, GK, go ahead.
Yeah, if you have any questions, you can unmute yourself, please, one by one. Otherwise, post your questions in the chat box.
Yeah, just post your questions in chat box, okay? So
Yeah.
I think it was a absolutely brilliant presentation, and for me, there were 2, 3 points which were absolutely amazing. One was, the difference between healing of intra-articular and extra-articular ligaments, and that's a very, very important point. That why intra-articular and how is the fibrin clot deficiency, in the intra-articular portion of the ligament, and that is, that probably would be giving us an in-depth analysis into how we should be augmenting it with probably more dose of PRP. The dose could be different for the intra-articular healing and extra-articular healing. That's what my thought process was. Or maybe that we can put the fibrin clot along with PRP there, probably. But that was a very good point that you put. I was really. The second is, which is very important, okay, because in India, we still have a lot of orthopedicians questioning us about the efficacy and really validity of biologics. And I think, how we start doing this biologics could be augmentation of our surgical procedures, be it meniscus repair or be it even ACL reconstructions, which can be augmented with biologics and giving better results. And third, extremely important, is that importance of ultrasound guided injections. As orthopedicians, we always say that, have done thousands and thousands of landmark guided injections, and I'm so good with the anatomy that ultrasound doesn't make sense for me, and which is not true. And you already saw his demonstrations as to, how you can be really precise when there are so many image guided things available. Why not use it? So I think these three were very important points for me. GK, you want to say anything, or you can just go ahead with the questions?
Yeah, better to go ahead with the questions. And
Yeah.
how to manage, the first question is how to manage the post PRP pain.
The PRP pain?
Yeah.
Yes, okay. Normally, in this kind of procedures to put PRP in the ligament, there is no very painful procedures. I have been pain in some patients with interarticular joint injection in arthrosis, because I have seen some cases of synovitis. It's a big reaction. If you have even leukocytes, a big reaction of fluid. But I have never used non-steroidal treatment, never. I always use analgesic or paracetamol or methimazole, but 2-3 days of relax, rest, the knee or the ankle. Sometimes I put a bandage if there is a big swelling, and analgesic only. About the question of Dr. Sharmila, I am totally agree with you also. When we use PRP like augmentation in the old room, the most important thing, obviously, is a good surgery, a good procedure. Obviously, to reattach the ligament. I do a lot of save the ACL. I do a lot of re-anclage of the ACL. We need to contact the healing of the ACL with the bone. And in the reparation of the ACL, we have to do a good reparation, stable the knee. But I think it's a help. This is a help to improve the resolution of the case. The second question about ultrasound guide injection. Yes, in my formation, like orthopedic surgery, there is two big items in my life. The first of one was the use the PRP with Dr. Michael Sanchez. I was to Vitoria in 2009, and for me, I opened my mind, and it was really emotional. And then 5 years later, 3 years later, I discouraged the ultrasound guide in 2012. I was a very surgical doctor, orthopedic surgeon. You like the whole room, but in the sport trauma master, I found uh, about the sport medicine doctor, the ultrasound, and for me, which was really amazing. I found a new field about the soft tissue problem, because the orthopedic surgeon was obsession with the
Yeah,
cartilage of the bone, and the
yeah,
fracture and fix, and the
absolutely.
screw and the prosthesis and then I found the soft tissue problem, ligament, muscle, tendon, and the ultrasound is obviously a very good stethoscopic, like the doctor,
Yeah.
to see the problem. And then I really emphasize and recommend to the orthopedic surgeon to use ultrasound in the clinic.
Yeah. So there's another question. Was it 7 ml pure PRP? Then how is the preparation? Um, so how much concentration basically you aim for ligaments? Because for joints we say that 5 to 10 billion. You know.
Now,
So
Sharmila, this is the typical question, no? The American school and the
yeah,
European school, in America, in Europe, we don't concentrate a lot, only +2, +3,
yeah.
no more. We think we don't need to high concentration. Um,
Okay.
it's the eternal discussion, but you are question to me, you are asking to me, and then I have to see you. My average is +2.7 to +3, like I
Okay.
have shown before. Um, Probably we can try to concentrate more and to compare the result, but nowadays I don't need to concentrate a lot.
Is it because you treat a lot of younger patients with sports injuries?
Yeah,
Because older patients would be needing more concentration. That's what my concept is.
I agree with you. You have seen is we are treating 15, 16, 17,
Yeah,
20. It's more and more younger
yeah,
the patient, and they are very good cells, very good healing, and we don't need to concentrate a lot. This is completely different to the arthrosis in the older population.
yeah. And I think you have already mentioned leukocyte poor scores over leukocyte rich for
Yes,
ligaments. Yeah,
I usually pour leukocyte always.
yeah,
I have almost never use rich leukocyte. Always it's only in fibrosis, muscular injury, or some chronic epicondylitis in the elbow. But normally I don't use because I have seen different synovitis in patients with when we use rich leukocyte inflammation, and we don't like, we don't use it.
There's another question. Could you please throw light on what braces to use for osteoarthritis? So I don't think, I mean, we had discussed osteoarthritis. We are on, sports injuries. How long when is the time to return to sports in athletes and rehab plan? Obviously, that will depend on what you have done. But what is your treatment? I mean, rehabilitation protocol generally. I'm sure I know that you have a very good rehabilitation center along with you, and it is. I mean, I
Thank you.
have sent some patients for that only.
I am normally very patient because I don't need a new re-injury, Sharmila. And then
Yeah,
I use a lot of brace in the knee, in the ankle, 3 weeks. I like a lot hydrotherapy,
yeah,
and, and then at 3, 4 weeks we start We educate to the patient también. Also, we educate because we have a clinical guide in our YouTube channel, and it's very relevant to educate to the patient. And then we start with the physiotherapy, and then with the functional reductor functional. I think it's very important before return to play to stay with the recuperation, with the functional recovery, to start with no more lesion. But my protocol, you can see in different book or internet.
Yeah,
Right?
thank you so much. So there's another question. In case of early osteoarthritis knee with medial meniscus extrusion, will PRP help healing meniscus, or should we refer for arthroscopic repair? I'm sure this is from the pain physician.
Yeah, this is a very good question. Like I told you before, 10 years ago, I was more surgical doctor and then indicate scope. But with the pass of the years, with to know the regenerative medicine and to understand, but to resect the meniscal is not a good idea sometimes because the osteoarthrosis is accelerate more and more. I only indicate the scope surgery in 3 cases.
Yeah.
When the patient has a block in the knee, bundle, with the patient has some instability in the knee, uncomfortable, and when he has a painful knee every day with no good recuperation with some pills or rehabilitation. I like to calm down because I have seen a lot of patients with painful in the clinic, and I decide to okay, we are going to wait 1 month, we're going to do the recuperation, and we are going to put a PRP and see you in 1 month. And I have seen a lot of patients in 1 month with the meniscal tears, and now he has no block, no pain, and he's satisfactory. And also, I have seen patient who has been operated by me or other college with suture or with meniscal reset, with painful, with swelling, with more arthritis. And then that's the reason I am more and more conservative treatment every year. I like to talk with him, with her. I am not in a hurry, we'll calm down. Except you have a handle, bucket handle, is a different pathology, This morning I have done 3 knee surgery. Then I am operate, every week, but my indication has decreased.
Gone down.
Yes.
Yeah. So there's another question. Is there any difference between healing of ACL tear in obviously partial in procedure technique, intra-articular knee injection versus directly instilling PRP into ACL tear site?
Yes, it's a very good question. I have many orthopedic surgeon friends that they are very surgical. They don't use regenerative medicine. I respect them. And when I talk with them about my experience in to put PRP in the ACL tear, they are, you are crazy. That's no indication. And the problem is that in the literature we have not yet a very strong literature evidence. But I can assure and promise that we are watching very, very good result. My indication are partial tears, no a big instability, it's a partial instability in acute lesion.
Okay.
Then I talk with the patient, I indicate, I explain, like I told you before, we are not in a hurry, we can wait. And I put, it's only 15 minutes procedure, it's very easy. You take blood, you prepare centrifugation, and then you put, orthopedic surgeon know perfectly where is the ACL in the clinic, in the medial portal, and then I use the ultrasound because in the cadaver lab I have training this to localize the ACL. You have to bend the knee a lot, and then you see in the tibia the insertion, but it's not obligate. It's not obligate. You can use blind procedure because it's very easy to know where is the anterior medial portal, you know, and then you put the 3-4 centimeter inside the ACL. It's not a painful procedure, and then in the joint you put a brace 3-4 weeks, relax, partial weight bearing, and then hydrotherapy, you know, functional recovery. And I have done more than 12 cases with good result. And if one patient is not a good result, then you do the surgery with the same probability of good result. Okay.
Do you think using a higher biologic would make give better result than just using PRP for this? Do you think that we could use either adipose or BMAC for these?
No, I have never used it, Sharmila. Never,
Okay.
because you know, the cells therapy are more complex. You need the old room, you need anesthesiology, you need to prepare the patient. Um, it's more complex, it's more expensive, and my results with PRP are good. That's the reason I haven't yet used it.
Yeah.
Other things, it will be if I do a reconstruction, I have the patient inside in the old room. For me, it's not difficult to take some blood of the iliac crest to aspirate.
Yeah.
But in the clinic, I always use PRP.
Yeah. Other question is basically whether you would be just okay with doing an intra-articular injection for partial ACL, or you would always want it to put in and try and put it in the ligament.
In the both, inside the ligament or intraarticular.
Okay, fine. So there's another question by Dr. Rohit. What is your take on PRP, on using it in partial meniscus tears and use of hyaluronic acid along with PRP in early osteoarthritis?
Okay, I use hyaluronic acid a long time ago, but every year I use less and less because in osteoarthritis I haven't seen very good result or a very short period of good result, but in 2-3 months the patient is again with pain. I prefer to use PRP in arthrosis, in knee arthrosis or hip arthrosis. For me, I have seen a big difference in the result. It's an anti-inflammatory, analgesic, and lubricant treatment, natural.
Yeah.
And with hyaluronic, no. And in partial meniscal tears, normally if we control the pain with a non-steroid treatment and a good recovery, normally I don't use PRP. In meniscus, I use PRP in 2 cases. In the surgery, when I do a medical suture, I like to do a biological augmentation with PRP. Or in the clinic, when I see a extrusion of the meniscus with a meniscal kyst and painful, very painful, typical painful, I use in the meniscal wall. I put the PRP in the meniscal wall and then inside. But if you are asking me about which is the tissue that you believe is less improved or effective, the PRP, probably I will tell you the meniscus.
Okay. Wow,
because,
that's a great point.
Yes, about the irrigation, you know, we need blood supply, we need oxygen. And the more fluid, blood fluid we have in a tissue, the best result you will have. The bone, in the muscle, in the tendon or ligament, and it's different, the cartilage of meniscus.
Yeah. So Dr. Ram wants to ask, and even I wanted to ask you the same thing. Is it better to inject PRP immediately after ACL reconstruction or wait for 3 to 6 weeks post-op? I was just thinking, I mean, there's fluid when we are injecting. Okay, so is it better to wait, that fluid to get absorbed and then inject PRP? What do you feel?
Okay. This this morning I operate also a posterior instability of the shoulder. It's a epileptic guy with 5, and then I repair the posterior labrum with 3 stitch implants, and then I put the PRP in the labral augmentation. I do the same in the meniscus or the ACL. The key is easy. If you are comfortable to
Yeah.
remove the water
Yeah.
and dry the joint, and you can see the tissue, because sometimes the blood you can see, but uh, normally I wait 1 to 3 minutes. I remove all the fluid, and
Yeah.
then when I see the tissue repair, and then I put the PRP with the articulation dry. Okay, but if you are not comfortable, you can wait 2 3 weeks in the clinic and to put the PRP
Okay.
after, as you
Okay.
feel more comfortable. But the question is very good. You never can put PRP with fluid in the
Fluid.
joint,
Yeah, exactly. Yeah.
the concentration,
Yeah.
and 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 never to put a drainage, open
Yeah.
drainage with a PRP, always, obviously.
Obviously.
Okay,
Yeah.
if you put a
Yeah.
drainage, you have to clamp almost 8 hours to wait for the result of the PRP, and then. But I don't like to put the drainage if I put PRP. If I need a drainage, I don't put PRP, obviously.
Okay.
Excuse me, sir. I have one question there. Most of that the count you shown is the leukocyte power. Usually we have the feeling of that suppose the tendons or ligaments, something like that. Leukocyte rich will be the better option than the leukocyte poor.
Yes,
How-
I normally don't use a rich leukocyte PRP, but only using in 2 cases. In the muscle injury, chronic injury with fibrosis, I prefer to use with leukocyte, and in the chronic tendinopathies in the elbow, in the epicondylopathies, chronic. But it's only 2 or 3% of my cases. Normally, I don't use leukocyte.
One more question, sir. Suppose you have the very dry knee. Suppose we have the little bit of fluid in the knee. Very easy to do that under ultrasound. Always easy to do that. Suprapatellar recess or some other recess you want to give that. Suppose the dry knee comes like that. Sometimes we are getting difficult in getting into the joint space. Is there any way of making it easy under ultrasound guidance?
In,
That you are using a lot of ultrasound guidance procedures.
yeah, in the old room.
And
No.
especially
No. He's saying that under ultrasound, if then sometimes the suprapatellar, so you are entering suprapatellar pouch under ultrasound guidance. And so when the space is very, very small and very difficult to negotiate, are there any tricks where we can actually enter ultrasound guided inside the tight knee?
Okay. I always say like the fluid is the best friend of
Yeah.
orthopedic, because it's very easy to see the anechoic image and to put the needle inside. I normally in that case I use other hand to touch the quadricep, and then to do the push, and then it's a little opening, and
Yeah.
sometimes I say to the patient to do a contraction of the quadricep. I have seen a small space to do that, but um, normally if you see the recess in the quadripetal space and the synovial fluid, there is a little smooth line. You can put the needle with no difficult procedure easily. But if you are not comfortable, you also can use the anterior medial portal in the scope to put the hyaluronic or the PRP or the cortisone in this portal. It's not very painful and it's easy to put. But in my case, 99% of the knee infiltration, I do the soft spot lateral, anterolateral portal, suprapatellar. Is not difficult procedure for orthopedic surgery, you know.
Yeah,
And
or otherwise, you can put probably, you can try and inject 5% dextrose in that space and just open it up and see whether it is really opening it.
yeah,
And then you
One
can put your biologic.
One more
Just
small.
confirm.
Now we are using the retropatellar space. It's very easy to do that, and we will
Yeah.
keep the retropatellar space and the needle in out of plane approach. When you go for suprapatellar recess, when you're injecting the fluid, it's nicely distended.
Yeah.
Retropatellar option, just like most of the orthopedists are doing blindly.
Yeah.
Yeah, we are using that. Retropatellar is very useful. Only thing sometimes we may get vascular injury. That is the one issue, that otherwise it's easy to do
Yeah,
that.
but generally, I mean, more cases you do, I guess, you just go better, get better with time.
I have a very good knee surgery in Spain, and he's very proud because I have never used ultrasound because I have done more than 5,000 infiltration in the knee, blind, no? And I talk with him and say, if you have done 5,000 of infiltration, probably 300 are
Yeah.
outside the joint.
Yeah, absolutely. So you're so
Yeah,
right,
because
actually.
you know, Sharmila, I always use ultrasound, and sometimes when I put the needle at the beginning,
Yeah.
I think I am out, and then I remove, I up the hand, then and put. Everybody put outside.
Yeah.
Yes, very true. Blind is always blind. We have given a lot of caudal injection that when we are doing fluoroscopy guided, we see that sometimes we failed even with fluoroscopy guided, it is going somewhere else. Yes, it's absolutely correct. Blind is always blind. How experienced you are, that's the very different thing. And ma'am's time is out. Can we go through quickly that? Is there any
Yeah,
questions?
please.
Best place to give PRP in chondromalacia patella. Always the chondromalacia patella is the question. It comes part of the session. We are doing that.
Wow, good question. Good question. We see a lot of chondromalacia injury. A lot of probably I always say is the most frequently pathology in my clinic, chondromalacia. Okay, normally 95% of the chondromalacia heal with a good advice, with a good rehabilitation, with the collagen, and normally with time. No, I had one in my knee, but there is a 5% of patients, even 16, 17 years, ladies more than men. They are a sport. They are very and there is no improve after 5-6 months. I always wait 5-6 months, no before, okay, because there is a natural process of healing in the body, and sometimes we have to say to the patient, okay, you have to wait, be patient, okay. But when 5-6 months are passed and the patient has painful, or he say, doctor, I am 2 years with pain, I am a golf player, tennis player, basketball player, I need a solution. And then in this case, I use the protocol of PRP, 3 sessions, 1 every 2 or 3 weeks, 10 millimeters of PRP, plus 2 or 3 concentration, normally 5 billion of platelets, ultrasound guide procedures. And I have a 100% of recovery in these patients. I have never operated chondromalacia with failed the treatment orthobiologic. It's different
So
of
in
We are
So
talking
the
about
question is, in chondromalacia, is there, I mean, is it only an intra-articular regular injection that you do, or is there some, where a different technique? Just
only
just an intra-articular.
we are talking about chondromalacia. We are not talking about osteochondral lesion, okay,
Yeah.
or
Yeah, exactly.
edema in the bone marrow edema. And
Yeah.
this is to put intraosseous PRP. This is the different tissue. No, in
Yeah.
chondromalacia, always PRP intraarticular is the same.
Okay.
And
And lots of people are asking which size of needle do you use for one intra-articular and the rest?
the green one, the intramuscular needle is a 25
23?
millimeters. It's a,
23.
it's a G18 or 21 or the intramuscular injection.
Okay.
So one more few questions are about what is the G force you are using to prepare your PRP?
The what?
Force, spin. What are
For
G force?
the centrifuge protocol, or are you using any ready kit, or you
Yes.
make your own
Okay.
PRP?
In my unit, in my regenerative medicine unit, Orthobio Sevilla, we have two systems of centrifugation. We have an open system and a closed system, and we have also a camera about the flow, and we have an EMO counter. This is this is a small unit. You only need, this is 3 centrifugator, a camera flow, and EMO counter. And the protocol are 7-8 minutes of centrifugation in, I think it's in 2,500 RPM. In open system, and in the closed system, I think is very similar. It's 5 minutes of 2,000 RPM. Okay, it's just, it's just a protocol of ACP arthrex I use. And for me, we started to compare the concentration, because we have the EMO counter, and then in the open system we start to prove with 5 minutes with high revolution, and then we count the salt. Then 5 minutes with low revolution, and then finally we saw the biggest concentration in 7-8 minutes of centrifugation of 2,500 revolution.
Okay. Yeah, fantastic. Louis Galligo, he's asking that what's your opinion about intraosseous PRP? Is it to be better done in the office or in the OR under sedation? That's a good one.
Yeah. Querido Luis, buenas tardes. It's my friend Luis Gallego. Is a fantastic orthopedic surgeon of Almeria, also in the south of Spain.
Hi.
He's a very, very nice guy. The DEVA group and the Spanish Academy of Regenerative Medicine, and he's very, very friendly. Thank you, Luis. Okay, this is a very good question, because it depends about your experience, about your knowledge about the patient, your empathy with him or with her, the age of the patient, the quality of the bone. Why? Because I have done ambulatory process with PRP intraosseous in older patients, in osteoporotic or osteopenic bone, with anesthetic, local anesthetic, because it's very easy to penetrate the cortical bone in the femur, in the older patient, and in the tibia, with a big the pink needle, it's thickness, but the green one. But at the end, it's depend about your protocol, about the money of the patient, because some patients, they say, oh, okay, doctor, I don't want to have pain. I prefer to pay a room, I prefer to pay anesthesiology, but I don't want pain. And then we go to the operation room and to do the procedure with local anesthesia and sedation. Okay, we use propofol or we use different. But if there is a young people or there is a cortical bone very strong, like a patella or like a distal tibia or other strong bone, I prefer to go to the patient to the old room and to do the procedure very calm down with no pain and to do the procedure in the talus. You can't penetrate the talus in the clinic with local anesthesia. You know, we don't need to have pain with the patient. You know, and then I prefer to go in the old room. But I have done different case in the clinic also, Sharmila.
Okay, that's
Thank you.
great. Yeah, GK, are there any? I mean, there are lots of questions.
Lots of questions. If possible, we will pass on to
Yeah.
questions to you.
And I would actually, we would want you to come back again once with, I just
Wow.
love your presentation on hamstring injuries and how to treat them. And I really love that topic also.
Yes,
So
yes,
we
I have.
probably, some other time we will just get you back here. What do
Yes.
you think,
I have to
GK?
inform you that we have the capacity of only for 100 people. So a lot of people are cursing us actually. Why you
Yeah,
are
actually, there is a lot of disappointment today that,
And
we had capacity of only 100 people and a lot of people had to be sent back, it seems.
so we request you to consider our things one more time. That time we will increase our capacity at least for temporary, and we would like to have one more session with us.
Okay, for me, it's okay.
Especially for the hamstring injuries and something like that. And
Yes.
most of the questions are almost repetitive questions are. So
Yeah.
almost one guided how to give that. We have almost we revealed the tricks of the 4 tricks of the how to
Yeah,
inject
I know. It is
particular ultrasound
lots of
also that.
repetition.
Please follow with us unless the questions are repetitive only. And finally, thanks from us, Dr. Pedro and Dr. Sharmila, to bring out the wonderful sessions exclusively for us. And we are very happy and we are honored and we are much benefited. And we like to catch up you again with your convenience later time. And you can share the questions to our WhatsApp group and things. If the Dr. Pedro is willing to share his email, we can compile all the things. We'll
Yeah, and we can forward him the questions, if people.
so a lot of questions are there. So if it take another 1 hour to if you go through all the questions. For thanks a lot being with us, and I see even though it is not our regular sessions because of Dr.
Yeah,
Pedro.
exactly. I mean, this was one in between on a working day and it had a beautiful response. And I really loved your presentation. And it was very on point, no fluff.
Yeah,
It's a really honor for me. Thank you for the invitation. I am very honored to come back again with all of you. It's my pleasure. And I would like to visit your country one time. And
we are going to get you here.
yes, yes. You can visit as me. You have my
Sure.
social meeting and we are in touch. Has been a really pleasure to stay with you this afternoon. We can repeat when you want. Thank you very much.
Sure.
Thank you very much. And a small announcement: this week Saturday session was not there because we have that radio frequency ablation workshop is there in our institute on Saturdays. So don't get disappointed. We will come back next Saturday with some more sessions. Thank you, Pedro sir. Thank you very much. Thank you, Sharmila ma'am. And we'll
Thank you so much.
Thank you, everybody. Thank you. See you soon.
Yep. Bye-bye.
Thank you.